How did that even happen?
Here, we'll have a guest today.
Aw.
It's an Hi.
Oh man, I have like, what is this, trigger finger over here?
You do have
But-
trigger finger. You really wanted to get this party started because we have a kick-ass guest today, and you didn't want to wait any longer.
No, I didn't.
Yeah.
So welcome back, guys, to the Unhinged Hygienists, where we say, well, we say the quiet part out loud. Well,
We do.
we do. We challenge old school dentistry and occasionally make people question everything they've ever learned in hygiene. Thank God.
And today, if you have ever looked in a patient's mouth and thought, oh, everything looks great, only for them to bleed like they've just bitten into a vampire's lunch, well, today the episode is for you.
And today I'm excited. We're hanging out with someone who has completely changed the way so many hygienists look at biofilm, bacteria, patient education. We have Tasha, who's an RDH, an educator, a consultant, and founder of TOSH, Teaching Oral Systemic Health. I love that. Love that. And we actually met a few years back at the Boots, Bugs, and Biofilm Conference in Nashville. And that was part of like, I did the integrative dental medicine. Then I went to this, and it was like really my gateway into the phase contrast microscopy. Because I remember looking like through the microscope, and I was like, ew. I was so concerned. I'm like, I better not have any spirochetes because I'm going to feel like really shitty about myself right now.
Question everything you've ever studied. Yeah.
Oh, but now we actually have a microscope sitting in our office at work that is just collecting dust. But
Mm.
I feel
Let's
like there's
change
something wrong with it. I actually have an appointment with a guy next week to kind of go over and kind of like problem solve because I want to get that going in office. So this is a perfect time that we're actually speaking with you, Tasha, today. So
It's really appropriate because I know nothing makes Tasia happier than seeing tiny little organisms having like a rave party underneath a microscope. So she needs her microscope back.
well, you know,
It's
it's
a
just
game changer. It is such a complete game changer. It changes the conversation, makes it so much shorter. I mean, it takes 2 minutes to explain periodontal disease when you have a microscope versus 10, 15 minutes to try to articulate the changes that the patient can't feel. So, yeah, it's
Mhm.
nice to see those creepy crawlies.
So let me
Hmm.
ask you, since I have you here right now, does it all, when you do the microscope and you put the biofilm in there, does it always move or are there times where it doesn't?
So, as long as you're close enough to the center plaque mass,
Okay.
and you're always going to have some movement, but there's a difference between the morphology of healthy bacteria
Okay.
and unhealthy bacteria. So there's very little movement in a very healthy slide. So you'll see tiny little specks with
Okay.
slight movement. It kind of looks like a very boring, lazy river. And at times you have to really pay attention because it almost looks like a still image. But then
Okay.
once you move into a moderate risk, you'll start to see
Okay.
these little guys pinging around, but it doesn't like totally gross you out. So then once you
Mhm.
move into the high risk category, which there's a lot of different looks for that, that's the frantic EBGB, oh my gosh, that's in my mouth.
Yeah.
So it makes it pretty easy to differentiate between low risk, moderate risk, high risk.
That's a
Those are
good way to
those
put
are
it.
the ones having the EDM festival. It's like
Yeah.
white chicks when they were at the club and do you remember?
Such a cultural reference. My
But no, because
goodness.
I was using it and I was like, it's not moving, nothing's moving. So I thought there's something wrong with the microscope. So we'll see when we do this on
Maybe.
Wednesday. So
This is
but
going to be a really interesting episode for me because I've never gotten to work with a microscope at all. And I have questions about all of it. So I'm thankful for you being here because I don't understand, because I'm going to look at it like the patient's going to look at it and be like, I don't know what we're looking at. So I think
Totally.
even just that quick explanation of the movement is pretty
Mhm.
interesting.
Yeah.
Because I mean, I want bacteria in my mouth. So how do I know which ones are good or bad or ugly? And then, how do you take that information and give it to a patient and make them understand it? So
Mhm.
I'm excited for today's episode.
Yep.
Me too.
Yes.
Yay,
I
yay,
want to
yay,
go
yay.
back to the beginning because you had said something that really resonated with me when you said, we have patients who brush well, they floss, they show up every 6 months and their mouths, they look clean, right?
Yeah.
But then they're still bleeding. But then there was that one patient you thought, something isn't adding up here, right?
Yeah. I think every
'Cause we see a
hygienist has
lot
had
of
that patient.
those. Yeah.
Yeah, exactly.
Yeah.
Because
How do you
we stand there.
explain that if
Yeah.
there's really they look healthy, but then you put that under the microscope and now,
Yep.
there's a
It's a
lot of
completely different story, and I mean, I've
Mhm.
told hundreds of patients probably before I knew better, before I had the additional, diagnostic capability. I would do my periodontal charting on every single patient. I mean, I know it's lost fashion to do a perio chart on every single patient, which I don't personally understand because
You
it's just
have
like
2 hygienists here who
We
do,
do it.
so yeah.
Yeah.
embedded into my DNA. Like, I need the initial
Yeah.
assessment. But so many of those patients, like, they don't have any bleeding. They look really good. They come in every 6 months and they're doing
Yeah.
everything right. And then I would say, "Oh my gosh, everything looks great, Lauren. I'll get you shined up and
Yeah.
we'll get you out of here. Like you came
Mhm.
in to get a bath." And then I would get
Yeah.
in there and all of a sudden it was like I hit an artery and I'd be like, "Does everything
Exactly.
feel okay, Lauren? Is it feel okay in
Yeah.
there?" "Oh yeah, totally
Mhm.
fine, Tasha."
Yeah,
Yeah.
no pain.
I would be
Yeah.
thinking, well, your numbers are quote unquote normal, healthy range. You do
Mhm.
everything right. You're already coming every 6 months. I can talk to you about brushing and flossing better, but there's like hardly anything to clean off in your mouth.
Yeah.
Yeah.
There's blood everywhere. And so for me, that was so frustrating within the first couple years of my career. And I even worked for a
Mm.
periodontist. And after I would do scaling and root planing and all the traditional therapies at the perio office, my patients would come in even that
Mhm.
they were so clean and they were so bloody. And I was like, "What is going on?" And within a couple years, I thought, "I don't know if I'm gonna be sticking in this career because this is a
Yeah.
bloody nightmare and I don't feel like I'm getting people better."
Yeah. We actually had this conversation a few days ago because, sometimes I was telling Lauren, I'm like, this whole bleeding on probing. What is the purpose of bleeding on probing? Is if once you start scaling, it is like a bloody disaster.
Yep.
Yeah.
Like, what matters more at this point? And like
Yeah.
you said, these are people who barely have any biofilm. Everything looks good. They're barely bleeding on probing, and then you're cleaning, and it's like, a bloodbath.
Yep.
What do
Mhm.
you say to those patients? And this is, I think, a good tool, you know,
Well, the
this along
difference
with maybe salivary diagnostics as well, but
which is also super helpful. And the
Mhm,
microscope doesn't replace salivary diagnostics. I think about the microscope as akin to intraoral photography and the salivary diagnostic being akin to the x-ray. So if I see a
mhm,
patient that has an old filling and there's all kinds of dark stain and it just looks really funky and it's in the back upper tooth. The patient can't see their upper back teeth, like not the biting
Mm.
surfaces. And so I'm going to take a photo of that because I want the patient to see, hey, I think there might be something wrong with this filling. It's no longer holding, it's not sealed. But
yeah,
and then let me also take an x-ray because if it looks really funky, there might be something going on that I also can't see. So with the
yeah,
Mhm.
microscope, it's kind of the same thing. Like it's a way for us to alert our patient that there's something wrong because the bacteria that we're looking at underneath the microscope are invisible to the naked eye. They're also translucent bacteria. If we can't see them, we most certainly can't. Our patients can't see them either. So with the
Mhm.
mhm,
microscope, you take a tiny little piece of plaque from their mouth, you put it underneath the microscope. It takes 30 seconds to take a plaque sample, potentially another 30 seconds to get it into focus. And then you see, is there healthy microbes swimming around or are
mhm,
there unhealthy microbes swimming around? And so it changes the conversation with the patient. It's not a fault issue and it's not a
yeah,
debris problem. It's an infection problem. The patient came in contact with some type of unhealthy bacteria. Their immune system didn't fight it off. It always will try, but it clearly didn't
Mhm.
succeed. If you have all these spirochetes and oftentimes parasites and all these other creepy crawly bugs on the
mm,
microscope slide. And if they have
yeah,
that in their mouth, their entire body is fighting off that infection.
I think one
and
of the
it's
things that makes me think about that I say a lot is everything we eat is not sterile. Because people automatically want to go, well, where did I pick up bacteria from?
mhm,
I do this, that, and the other. And it's like we're literally ingesting bacteria probably 24/7, because especially if you're breathing through your mouth.
Mhm.
And so, what do you do if somebody you do have, for example, what you were talking about, the patient who comes in with the great home care,
Yeah.
they have basically no plaque, no biofilm, nowhere. Where do you
mhm,
collect the sample from?
So
great
I always
question.
like to do a periodontal chart first and figure out
Okay.
where is the deepest pocket. And even if that
Okay.
pocket's a 3, I'm totally good with that. I'm
Yeah.
going to try to find an area that maybe is a little bit trickier for the patient to always do a really great job with their home care. And typically you can find that after you've done your perio chart. So my favorite is mandibular, lingual, interproximal. So I would just take
Mm.
my Explorer and then you'd use a
Mhm.
scooping motion attached to the tooth. So you don't want plectonic, free-floating bacteria from the pocket, you want attached
Okay.
biofilm because that
Gotcha.
has the ability that's been maturing for a little while, and that's gonna be
Okay.
your best bet. So you just scoop that out and then you put it on the microscope slide. If you have somebody that has immaculate home care, let's say they use a water flosser on a regular basis, you probably want to go around to, 2 to 3 areas to try to get some biofilm. And usually you can. I mean, it's very rare that somebody
Yeah.
did a perfect job in, 360 degrees around every single tooth.
Exactly.
I don't ever recommend using anterior teeth unless there's deep pockets.
Yeah.
It's just you're just not gonna get as much
Yeah.
much biofilm, and also, like, when we eat, there's too much disruption in the anterior, our social 6 on the top and bottom, as some
Yeah.
people
Yeah. Social
so
6. Yeah.
so the
So
posterior
that's
molars
very
are
helpful
definitely better, and
because
so
I
then
feel
you're
like I was
wondering
not doing that. So thank you.
yes,
That's
there's
interesting. Yeah.
a lot of little
Yeah.
tricks over time that can make
Mhm.
the biggest difference. You also don't wanna get supragingival plaque because supragingival plaque is fresh and new. And so if
Mm.
let's say you have a patient that has really poor oral hygiene, not on purpose, they just forget that you should also brush the linguals, let's say. So you really wanna wipe away all the supragingival plaque because all of that's gonna look healthy because it's not mature. It's kinda like when you
Mm.
disclose. So if you use, like, the tricolor disclosing solution, we've got the 3 different colors. One's, the
Yeah.
acidic, and then the other 2, how long have they been there? None of those are anaerobic bugs that we're looking at under the microscope. That's all supragingival stuff. So it's
Mm.
all gram positive. So we're looking for
Mhm.
different stuff, but it's still helpful information because it still shows the
Mhm.
patient, "Hey, Tasha, you're missing all your floss points." Like, "You're
Yeah.
doing a really great job on a
Yeah.
couple areas, but there's, there's a whole
There's
nother
more.
in there." And so when we can show the patient the unhealthy bacteria and it looks kinda creepy crawly. I kinda compare it to if a cockroach ran across the floor, just innately as humans, we're kinda like, "Oh, gross." And so you get
Mhm.
that visceral response. And the benefit of that with the patient is now you really truly have their attention. And now they're going, "What
Yeah.
is that?" And then even if they're one of our analytical type patients that really needs a lot more information, it logically makes sense. So we hook them with the emotion, but it also
Mhm.
logically makes sense. How did I get this bacteria? Where did this
Mhm.
come
Mhm.
from? Those are great questions because now we're having a back and forth conversation,
Mm.
which I think, for me personally, in the early days of being a hygienist, I mean, I just verbal vomited all over everybody with
Yeah.
all the problems and
Yeah.
then the solutions and then the financial part. And they
Yeah.
were, their hair was blown back. They had
Yep.
turned into
It's
a bobblehead.
fireballs.
I thought, yeah, they're listening, they're
Yeah.
understanding everything.
That's what
And
I
then
do
they'd say,
sometimes.
"Can I just put my teeth clean? I gotta think about this." And I was like,
Uh-huh.
"No, I don't have time. I've just been telling you that
No.
you have periodontal disease."
Yeah.
Yet nothing that I said sounded anything like an infection.
Hmm.
It's
Have
true.
you found that this is the best way to make the patient be actually involved in their own healthcare, in their own
Oh,
dentistry?
night and
Because
day.
you're showing them. Yeah. Okay.
I hear that all the time. Even, the teams that I work with and, some of the hygienists that tend to be more apprehensive at first. And when we talk about, just initially the high level of how this is going to look down the road, I can see their faces going, "I don't know, Tasha. Okay, I'm going to stick with you for a little for
Yeah.
this, but I don't really know." And then at the end of training, when they're using it and they're seeing the light bulbs going on and they're using the new verbal scripts that I've coached them on, they say, "Oh my gosh, that's so much easier than I thought." And I was
Mhm.
the one who was afraid of it. And my patients are totally accepting of all this. My patients
Yeah.
want this, but
Mhm.
we're afraid. We've had so many patients that have, maybe not believed us, or maybe not so
Yeah.
many, but the patients that don't believe us or that get really upset about what we tell them can make us a little bit shy to
Mhm.
really truly
Yeah.
express the problem that they have.
Yeah.
Um, and so I think sometimes we tiptoe around it too much.
Mhm.
Do you ever get any pushback from patients? You know how, like, sometimes because we both use a Tri-Gel and we disclose, and they're like, "No,
Yeah.
that's I just brushed. This is," and it's like, "Well, clearly not well." So, do you ever
Mhm.
get patients where you do show them and they do have really bad, like, microorganisms flying around in there that say, like, are in denial?
Mhm.
Um, yes, but so few. So
Okay.
I would say less than 10%. I mean,
Okay.
out of 100
Yeah.
patients, maybe 2. I mean, it's so,
Because
so
what could they say? You
Right?
literally just pulled it out of their mouth.
So that's good. So it ties in that connection and it
it does.
puts it together, makes a big picture for them. I
Yeah.
like,
Mhm.
and
One of
how
the
would you
common questions
implement this?
I'm sorry, say that again?
Like, how would you like, where do you do it on every patient, just new
No.
patients?
No. So the reason so in a perfect world, absolutely, Tasia, take it on every patient. But most of us don't work in a practice that has the available hygiene hours.
Yeah.
So the way that I start teams with is we first work on your schedule. So we work on block
Mhm.
scheduling because if we don't have time reserved specifically for our patients that have infection, you're going to do the bloody prophy and we're going to talk
Yeah.
about home care or the bloody perio
Yeah.
maintenance and we're going to kick the can down the road and we're not able to take action because I don't know about for you, but for me, I have a really hard time telling somebody, oh my gosh, you have a serious infection. I'm so glad that we found these bacteria on the microscope slide because if they're in your mouth, they're in the rest of your body. Maybe my patient has diabetes and I'm like, and they told me that their A1C was an 8. And I know if I can get them healthy, that their A1C is probably going to drop to a 6 within 2 months, right? 2 to 3 months. I mean,
Mhm.
science shows that there's a direct connection, even with old fashioned scaling and root planing. So I don't want to freak my patient out when they're already freaked out about seeing the microscope slide if I don't have a
Mhm.
treatment visit available.
Yeah.
So when I work with teams, the first thing that we do is you got to look at your schedule. You have to block
Mhm.
time. And if that's months out, then do that. So, and then every single day, based on how many people you can accommodate, then we start taking that many slides. So maybe that's
Okay.
2 slides a day. And then you grab another slide on somebody that you really think is healthy. But I always caution people on that because I have been guilty of telling somebody, oh my gosh, everything looks great. I'm going to take a microscope slide. You're going to get to see what a healthy slide looks like. And then I look at the slide and I'm like, oh my gosh, you have spirochetes there. Oops.
Wow.
So,
But I think that's the point, right?
Yeah.
Because not only do we have the old saying of nothing hurts, now we have nothing looks bad, nothing looks
yeah.
scary. But I mean, like you said, we can't treat it if we can't see it. So
Yeah.
what's the next step? So here you go, you found something. What do you do
Yeah.
next?
So the next part is really ensuring that the patient understands that we found something different, so we need to do something different. And so what I
Mhm.
would say to a patient when I'm doing their periodontal charting is if I see any type of inflammation, I'm going to initially say like, "Hey Lauren, I'm seeing some changes in your gums today. You have redness, inflammation, and even bleeding." I coach teams to never use specific spots like, "Oh, Lauren, I'm finding some bleeding points on your upper right." Because now you
Mhm.
think that that is just a problem on your upper right because
Mm-hmm.
you don't know if you're a patient that everything's going to bleed when I start cleaning it even though it doesn't hurt at all. And
Mhm.
so I want to make sure that the patient understands this is a full mouth infection, even though some areas might present worse than others. So I will alert the patient if I see something concerning. But if I do plan to take a slide on them and I don't see anything concerning, then I'm going to say my initial evaluation looks pretty good, but we want to double check with the microscope because sometimes we can have some unwelcome visitors in there that we don't want. So then we go to the
Mhm.
microscope, we look at that. If it doesn't look good, then I'm going to draw it back. Like, wow, this definitely explains the changes I was seeing in your gums today, Lauren. These bacteria like to live inside your gums, not just on top of it, which is
Mhm.
helpful to the patient because then they know it's not a fault issue. I think hygiene and hygienists for many, many years have been trained to coach their patients on what they need to do, but it's
Mhm.
turned into a lot of lecturing. And then they
Yeah.
feel
Mm-hmm.
bad, like, oh, I don't, the last time I flossed was the last time you did it. It's like, I don't need to hear about it. And because it makes them
Yeah.
not even want to come in and not listen to
Yeah.
us because we just sound like a nag. And
Mhm.
that's not helpful either. So to me, I like to make sure that I'm having a really open dialogue with my patient and they don't feel like I'm attacking them and I want to have that back and forth conversation because people don't buy solutions to problems they don't perceive to
Mhm.
have. So after
Yep.
I show them
True.
that, wow, this definitely explains the changes, then I would say, Lauren, what questions do you have about these changes?
Mhm.
Because if you're just like, oh no, Tasha, everyone's got those, I'm not really worried about that. It'd be helpful for me to know that
Mhm.
before I started telling you what treatment you had, what you
Yeah.
need,
Mhm.
treatment you needed, for
Yeah.
example.
Yeah. Interesting.
Yeah.
Yeah.
See,
And
No,
then
this
that's
is I love the open end. Yeah, it's just 100% open-ended questions
yes.
from there. So,
yeah.
okay. So then when you say, okay, now that we've seen something different, we need to treat you differently,
Yep.
where does that lead to?
So my next step would be to talk about the lab test to find out what specific bacteria they came in contact with that made their mouth sick. So this is truly oversimplification of the problem, but we need to speak in my opinion, we need to speak in terms that our patients can easily understand what the next step is versus going down the
Mhm.
rabbit hole of
Yeah.
microbiology and science and
Yeah.
everything else. So I explained to them that on the microscope, we know certain shapes are not part of your good bacteria, but we don't actually know what they are without a lab test. So the next step is to find out what specific bacteria you came in contact with, Lauren, that gave you this infection, and make sure that you say infection. And then they're gonna be like, "Yeah, okay, that totally makes sense." Okay, now and then depending on where your microscope is located, some people put it on a mobile cart, some people take their patient on a field trip. There's a billion different ways to do it. Some practices have a microscope in each hygiene operatory. What an amazing world. I had that later on in my career. It's so incredible because then you truly can start taking slides on almost every
Yes.
single person. But time is always the factor here. So the next step would really be, okay, let's talk about, how we found something different. So we need to do something different. And then from that portion of it, that's when we're getting into that treatment. So think of the cleanings we've been doing like a routine car wash. But what you now need is more like a full detail, really spending time getting in the nooks and crannies, places we just can't reach. And we truly need to use some medicine because you have an infection. So if a patient has tons of calculus, I genuinely don't talk about that. Like, I don't talk about how much calculus they have, what their pocket depths are. That information is for us. My husband and I have been together for 20 years. We've known each other, well, we've known each other for 20 years, friends, and been together for like 15 years. He he dated a hygienist before me. He doesn't even understand the difference between a 3 millimeter pocket and a 5 millimeter pocket and the what had to happen for the necrosis of the
Yeah.
jawbone. So a lot of us, I think, myself included, in the early days thought, well, I've explained this process to them so that they
Yeah.
know the difference of
Yeah.
2 millimeters is huge. 2 millimeters is like nothing.
Yeah.
When we're showing
To
our,
most people,
our
yeah.
probe, and
Yeah.
they're like, that is not a big deal. I've got more lint than that in my pocket. So it doesn't seem that tangible. So for me,
Yeah.
I would rather say you've already lost some of the jawbone because of this infection. I like to think of it like termites in the foundation of a house. Like these bacteria live inside, not just on top, because I want to paint the analogy so that the patient goes, oh, I get that. Like that totally makes sense. Versus pocket depths are just not, that doesn't sound like an infection to me.
No.
Yeah.
Yeah.
That's a
No,
good way to put it.
it is the jawbone because, most of us say, "Oh, you have some bone loss. The bacteria has gone in there and eaten your bone." But when you say jawbone, now it becomes more of a serious issue. It's like your face. And I think that's great. Well, because you need analogies for patients to understand as well, to kind of paint that picture because they don't get it, you know?
It
I have a
allows
lot of
us to
patients that come in
communicate.
for periotherapy and they're like, "I don't have perio disease." And I'm like, "Yes, you do. We've talked about this, sir."
Yeah.
That's
Just
treating
not
you.
you. Yeah. Well, I think to your point, like this, the words, the scripts, the
Yep,
specificity is very important
it is.
because I joke that I always bring things back to like construction and the house and the foundation and rebar and everything else. And I think really changing the way that we have talked about it. And then I really like the using the inside of the pocket,
Mhm.
the jawbone, and this sort of different way to present it. Because, like you said, what's a pocket depth mean to
Yeah.
anybody? And the best thing I've had so far is, well, you think to a bacteria, a millimeter or two is the Grand Canyon,
Yeah.
but it's that's good visualization. Thank you for
Yeah.
that
Yeah, that is
that
great.
nugget. Yeah.
I'll be
Okay.
using that.
So now
Mhm.
you've found it. Now you
Yep.
have the infection. Now you say, okay, we're gonna send the slide. So do you do like a paper point
Yeah,
or
so I'll do
what's
so I work with teams all across the United States, and some of them use like oral DNA, some will use microblink DX, and there's a couple other ones out there that people will use, and then I have some other
Mhm.
countries that use different kinds. So I'm as long as you're testing, like that's the most important thing. I personally love the paper points because you have so much specificity to get it into the deepest part of the pocket. So, clinically, I've used the swish and spit and I've used the paper points, and I do favor the paper points because
Mhm.
if there's a 7 millimeter pocket, I want to get that paper point to the
Yeah.
seven
Yeah,
millimeter
yeah,
pocket because
Yeah.
we know that the concentration is going to be deep, is going to be much higher than just what we're able to spit out,
yeah.
provided the patient
Yeah.
can spit really well. But I'm happy if people are testing truly. I mean, most
Mhm.
practices across the United States are not testing at all. So I'm just like slam dunk if we're testing because it
Now
just gives
I
us.
have the devil's advocate popping into my brain here, right? So now I'm the patient, you've found this, and I don't know that there's anything wrong, and now you've told me there's something wrong.
Yeah.
Do you then try to, because all I think about is, well, it's like me with airway. I just had this discussion with a grade 4 tongue tie the other day who he said, well, I don't know I'm 54 years old and I don't notice anything's wrong. Why
Yep.
should I do all of these things? Why should I do myo? Why should I do a tongue tie release? So here you have this patient who has had rampant periodontal disease living in their body for
Yep.
God knows how long.
Mhm.
And now you've said, okay, well, now I'm going to spend more of your money. I'm going to take more of your time. I'm going to do all these things. So then, like, I'm curious about how you progress this conversation, because obviously we're healthcare providers
Yep.
and you came to me to give you the information. You're not going to ask your nurse or your doctor to give you half of the info, because then you're going to be mad about neglect. And
Yep.
I'm not here to neglect you or soft sugarcoat things.
Yeah.
You bring me the news, I report it. So what's next?
Yeah. So I really follow like Marie Forleo's Simplify to Amplify. And so if a patient isn't asking me a bunch of oral systemic questions, and their medical history is very uneventful, I'm really not going to bring up a whole bunch of extra. Like my goal on that first day is to help them to understand what infection that they have, what I recommend, and tease out as many questions as I can. All
Mhm.
Mhm.
before I ever go over the financial part of the whole equation. Like because I don't even want to
Mhm.
go over any money, any how much does it cost to do all this until I know that the patient's engaged and cares.
Sure.
If
Mhm.
if I have a patient that their medical history says that they have sleep apnea, for example, I'm going to be bringing that up. I'm going to be asking how are they managing their sleep apnea, and they're
Mhm.
like,
Mhm.
oh yeah, I wear my CPAP every night. Then my next question is going to be, how do you clean it and how often? Because
Mhm.
that's a horrifying
Yes.
question right there. Um,
Yes.
Mhm.
Mhm.
because they've
I'm
That
supposed to clean
biofilm.
it? Oh, yeah. Yeah, exactly.
There's been studies on aligner systems and the bacteria that grow on there. It's the
Oh,
same old thing. Um,
yeah.
Yep.
so are you recontaminating yourself every time you go to bed? So
Mhm.
so there's some barriers there potentially for really totally achieving full body health. So I'll get into the oral systemic conversations potentially over time, but only when they come up right away. Otherwise, um, I love the book from Jefferson Fisher, The Next Conversation, and he talks about how the more words you use, the more diluted each of them is. Whereas the opposite
Mm.
is also true. If you use less words, they're more concentrated. And
Mhm.
so if I continue on and on and on and on and on, all of a sudden I sound like I'm selling something.
Yep.
Now you got the bobblehead again.
Yes. Yep.
And I
Yeah.
don't wanna enter that territory at all. I wanna
Yeah.
provide objective data, allow the
Yeah.
patient to ask questions, and hopefully they enroll in treatment, and then I talk about, like, the three-tier approach. What are we gonna do for you in the office? What are you gonna do for yourself at home? And what about your immune system? And so I'm
Mhm.
gonna move
Mhm.
into that, and if we get into more of the oral systemic over my multiple periodontal visits, because we need multiple visits too, because the
Yep.
bacteria like to rebound, or they will rebound. So I will tease into those areas as we need to go along. But for me, I just don't feel like we need to dump that bucket on them when we
Mhm.
diagnose. That is not the most important thing. The
Okay.
long-term relationship with that patient is how we actually get them healthy. I mean, it's
Mhm.
a New Year's resolution. I threw the kitchen sink
Mhm.
at that patient. I expected them to do everything. They really gave it their best effort for, 2 to 3 weeks, and they just fell off the wagon.
Yeah.
Great.
And
Nobody
we're all
wants it.
guilty of that, I'm sure,
Oh, yeah,
Yeah.
I've done
We
that.
try to, and a lot of us have to I do it, I still try sometimes. It's like you don't have a lot of time, so you're just trying to get as much information
Mhm.
out there as you can, but now I'm starting to learn to, okay, pause, let them
Yep,
answer,
yep,
Yeah. Take your hands out of their mouth.
you
Yeah.
know?
Yep.
Let them
Well, and I
think, post that, if you have the
yeah.
the salivary, like, just leave it there. I'll sometimes leave pictures up and walk out of the room for a
Mhm.
minute.
Mhm.
yep, yep.
That's
I
Well,
what's probably even better about the psychology of this conversation you're having is they're still sitting up.
Mhm.
We're not talking to them lying
no,
back. We're
no.
not over them.
Yeah.
That's because even that can change the dynamic of how the
Mhm.
conversation goes.
Oh, 100%,
Yeah.
100%. And then even when the doctor comes in to do their evaluation, the way that we hand off to the doctor is super important as
Mhm.
well. And we have to practice that and make it a habit with all the hygienists and the doctors in the practice so that it's very consistent because we really want to, for lack of a better way to say it, train our patients what to expect of us. We want them to know that we're your healthcare provider first and we really care about you at the same time.
Mhm.
But that doesn't mean that I'm going to ask you about your family, your friends, and all your vacations first. Like I need that.
Mhm.
That's good for me to care about that, and I do as a
Yeah.
human. I always really
Yeah.
cared about my patients. But our first and primary role is a healthcare provider, and we
Mhm.
should be telling our patients what we see. And if we get
Mhm.
some pushback from them, It's usually because they don't understand. You know, for me
Yeah.
in the early days, especially, I used to like get freaked out about certain questions because I thought people were questioning me. And I thought, oh my gosh,
Mhm.
they just don't think I know what I'm talking about.
Yeah.
But later on, I realized that they're just asking questions. And
Mhm.
everybody has a different personality. And so
Mhm.
some of those questions can feel a little bit sharper than
Mhm.
others. And then there's other patients that have a very soft demeanor and then they'll cry in your chair. So
Yeah.
it's just a different way of going about it. None of it is bad. It's just
Yeah.
you, like, as the clinician, we have part of what we didn't necessarily learn in school was how to navigate those conversations.
Yes.
Like, I didn't have any
Mhm.
verbal skill training in school, and I have taken
Nope.
countless classes and continue to, because verbal skills and scripts, even though like I'm known for my microscope training, the verbal skills and scripts is something that I work on every single call because I believe that that is the most important thing that we do. Because if
Mhm.
people can truly understand what we're talking about, we can speak to them on a level that
Yeah.
they get it. Nobody feels offended. Everyone feels like we're having a
Yeah,
great conversation. That creates long-term change.
it does.
And
That's because 'cause
that's
you're connecting.
something I
Yeah.
wanted to get into as well too, because I think a lot of us will talk about airway or, bleeding gums aren't normal. And then you have the patients that are like, well, I've always bled this way. This is
Mhm.
my
Yeah.
normal. It's never bothered me before. It's never been an issue. And then it's like a
Mhm.
lot of us don't know where to go from there. Like, what do
Yeah.
we say? Because it's like, yeah,
Yeah.
this has been
My
their
mom
normal. They've had
bled. My
airway
grandpa
issues.
bled.
So,
Yeah.
Yeah, we've
Yeah.
all been bleeders.
yeah.
It's like,
But that
So I,
doesn't mean that it's okay.
yeah.
exactly, exactly, and that's kind of those are some of the hardest conversations are the patients that are
Mhm.
like, "Well, this has always been a thing. Why are you talking about it
Yeah,
now?"
Yeah.
exactly. Yeah.
Yep.
Why now? And I think that's that beautiful phrase of, well, we now know and science now tells us. And I think
Yep.
people appreciate that we are advancing our own education for the sake
Yep.
of them.
Hmm.
And but to your point, like I like that you can now you have verbal skills and language to then tease out the information that then is going to make it pertinent because nobody cares about anything until it affects them directly,
Yeah.
right? And
100%.
so then the medical health history and to the point of staying up to date with everything, health histories, medications, even perio charting,
Hmm.
all of your intraoral, extraoral, lifestyle, CPAP, like these are such important parts of all of
Yeah.
this that even diet, like now I want to know, okay, what did you eat? What are you drinking? What's going on
Hmm.
here? Because my myo and airway training, I'm instantly like, what does this person's mouth? What's the frailty of their tissue? Is this where I could take this conversation? Because I have a microscope sitting in my operatory that I have literally never touched. It stares at me like it's a beautiful trophy on my wall. And now I am itching to get to work on Monday and buy some slides. I'm like, because I am a
I'll send
biological.
you a list of exactly what to order. Don't just order anything, please.
Please,
Please don't.
please. I mean, I would
There's
love it
there's
because I'm a biological hygienist who's
yeah.
not doing microbial testing. Shame on me. Like,
And
I'm
that's
really
why I
excited
loved
about
this
this.
episode today because I've talked about you and bacteria and pathogens with Lauren so much. And and this is like great because I know I love the questions
Yeah,
you're asking, Lauren, because I know you genuinely want to learn more
I'm
because
curious.
it's
It's
true.
fascinating.
But then it's like, where do we go? So, like, okay, they have
Where do
all
we
this
go is the
bacteria, they
question.
have
Yeah.
spirochetes.
Yeah.
Now we're doing non
Yeah.
surgical
Now what?
periodontal therapy. What else are we
Yeah.
doing?
What's next?
For the treatment, you mean?
Yeah.
So I would
Like,
guess
was there
based on
products or like what is
yeah, so based on
beneficial?
what I know of you fabulous hygienists that are so ahead of the game is your treatment probably is correct and really great. There might be a tiny, a few areas to massage here and there based on the specific patient, the patient's needs. Um,
Can we tell you what we do and you tell us if we're correct?
sure.
No,
Go for
just
it.
tell
I'm
me the
a,
protocol.
Okay, fine.
No, I don't. Don't waste her time. No, I. You're gonna assume
Okay.
that we're awesome and we're doing all the things we're
okay,
supposed to
tell me no,
do.
no, tell me what you do first. That is because truly well, okay, so let me start back when I first started using bacteria testing in 2008, January of 2008. Started working for a practice in Nashville. That's where Jennifer Sider was working. They had started using some saliva testing in 2005. So they'd been testing some patients. The doctors showed me like these amazing results that they were having, and I was just wholehearted perio hygienist from the moment I graduated. I wanted to work for a periodontist. I want to change the world, which is why after a couple years, I was just like, "Oh my gosh, this is not what I
Sure.
thought it was," and I was so sad, but I stayed super
Yeah.
curious because I thought, "There's got to be a way
Mhm.
to stop my patients from bleeding. There just has to be."
Mhm.
And so when I moved to Nashville and one of my girlfriends, also a hygienist, said she's like, "Oh, there's this dentist, he's like all perio, Tasha." She said, "I just heard that he's hiring, so you should fly down and
Mhm.
go interview with him." And so when I did, I mean, he was talking about bacteria testing and regrowing bone and all this stuff that I was taught was not possible. So once I started working there, it was it was incredible the results that we were seeing. And so they were still kind of figuring out the systems. And so then together we kind of teased out what worked, what didn't work. The reason I bring all that up is that I didn't have GBT then. I didn't have a laser back then. I had a Cavitron with a dual select. We used chlorhexidine, and couple of the hygienists were like, "Oh, sometimes I'll do a water pick, sometimes I'll do an electric
Mhm.
toothbrush." And I was just like, hardcore, no, everyone needs a water pick, even if you only have 2 millimeter pockets. And even
Mhm.
back then, like I didn't fully understand the science, but I just knew that when I would see their patients, there would be more bleeding than I felt like my patients had, and they weren't using a
Uh-huh.
water pick. And these are more your gingivitis patients. So they're more advanced patients. They always got them on a water pick. And
Yeah.
I also was just one of these crazy teaching home care kind of people for most of my career. Like I certainly kind of fell off the wagon a little bit for a while and then realized that that was the missing link to everything.
Yeah.
And I needed to like
Yeah.
hand my patient the toothbrush and say, "Show me what you're doing," because that tells you everything.
Mhm.
Versus
Mhm.
just tell, let
Yeah.
me verbal vomit all over
Mhm.
you. And so at that practice, I saw bone regrow on dental implants. I saw bone regrow on vertical defects using salivary diagnostics, disrupting and disorganizing the biofilm, talking to the patient about what they needed to do. We used chlorhexidine way back then because that was the gold standard then. I wouldn't use
Yeah.
that anymore, but you
Yeah.
do what you know to do at a certain time. And now there's better
Yeah.
products out there. Now I would use ozone and
Yeah.
lasers and guided biofilm therapy and everything else. Um, but I still saw bone regrow. It wasn't like these people were on chlorhexidine, just for the record. They weren't on it for more than like 10 days max at the very
Yeah.
most.
Mhm.
So the science shows over 6 months is bad.
Yeah. Yeah.
But
Yeah.
still,
There are
I
studies.
still like
Yeah.
there's better products out there now,
Yeah.
and
Mhm.
there's so many products out there now available to us. But I know that you can get incredible results without having every tool known to man. Um,
Mhm.
is it fun
Hmm.
and great and awesome to have all those fun tools? 100%, it's awesome.
Yeah.
But
Yeah.
it's
Yes.
not. But I don't think that it's a feasible way for most practices to start if the practice owner is going, "Oh my gosh, now I gotta buy this, and now I gotta buy this, and now I gotta
Yeah.
buy this." My hygiene
Exactly.
department is just doing prophies right now. Like, how do I implement all of that? I mean,
Mhm.
it's a tall order. So, what you're
'Cause I've
doing,
talked to
there's a lot of more to
hygienists
go.
that yeah. No, because 'cause I've talked to a lot of hygienists that, they don't wanna do the lasers. They don't wanna use the guided biofilm therapy because 'cause they're like, "Well,
Mhm.
I've done ceiling and roof planings my whole life with just this, and it's fine.
Yeah,
It's worked. I see
yeah.
results." And I'm like, "Well, how is that really benefiting your patients, really?"
Mhm.
Like,
The question
if
that
you
that
have the
I ask,
tools
it it's sometimes instead of having the argument kind of, for lack
Mhm.
of a better way to say it,
Yeah.
my
Mhm.
question tends to be around because okay, so I have these 2 teams that pretty much trained at the same time a couple years ago. They graduated from the program, they were doing really good, and so now we have, like, calls every other month. And so they both kinda ran into the same thing, but all of them were saying like, "Okay, like, we've tested most of our patients now, and so, what do we do now? Like, we feel like we're kind of, at a standstill. We're not really
Mhm.
diagnosing anymore. Do you just, like, run out of people to diagnose?" And I was like, "Well, let me ask," and so you can answer this a lot of the ways, right? And so I so I went around to every single hygienist and I said, "How many patients do you have a day that do not bleed at all?" I ask all my team
Zero.
all the
Right.
time.
Yeah.
Not
And
many.
the
Yeah.
answer is always the same, no matter if you're a GP practice, bread and butter practice, or if you are a
Mhm.
biological practice with every tool. Maybe 1 or 2.
Yeah.
So if
Yeah.
you have maybe 1 or 2 patients that don't bleed, has your has the periodontal disease, like, have you really gotten rid of it in your practice? Or are we maybe not having as many conversations as we could be
Mhm.
having?
Yeah.
Because
Mhm.
the later perio, the new patients, those are the easy ones. It's that
Yeah.
earlier gingivitis. There's some
Yeah.
4s, maybe a 5 here or there. They do a
Yeah.
really great job with their home care, or they don't have pockets, but man, they do have recession. There's some black triangles there, but my gosh, they have immaculate home care.
Mhm.
Those are the people that fall fall between the cracks.
Between the yeah, cracks,
Um,
yeah.
and those are the trickier ones. And so it's like, well, who doesn't bleed? Because
Mhm.
that's going to tell you, have you arrested the infection? Or are we
Right.
managing the infection? Are we trying to like manage it with perio maintenance, but they're not healthy? Are we maintaining health or not?
That's why I've always said, how many people are true actual prophies?
Very
Not
few.
many.
I
Yeah.
feel like the major insurance should be covering like 43, 46 as a prophy because most patients do not fall under the
Mhm.
30 or less
There's a
percent of
misconception that you
yeah,
need
it's
30% bleeding
yeah.
points. That
Yeah.
that is nowhere in the nomenclature. That is nowhere in the ADA or the CDT book. It is 30% bleeding.
Yeah.
Mhm.
Regardless of what certain insurance companies will say. But what I teach teams is you're if there's rejections with insurance companies, we're arguing with AI. So you need to
Mhm.
argue back with AI and have
Yeah.
an appropriate narrative because a lot of
Yeah.
times you can get benefit on these things that are initially are rejected, which is a hassle. It is.
Yeah.
But if
It
we're
is.
taking insurance and we're helping our patients to get the coverage that they want, and that they deserve to have with the insurance coupons,
Mhm.
it takes a little bit longer with some people, but I
Yeah.
mean, it's kind of it's part of dentistry. It's part of dentistry. It's not a
Yeah.
fun part of dentistry, but it's part of most practices.
Yeah.
So now I'm curious because I know Lauren's at a biological office, I'm at a GP. We've never really talked about what we do with our patients for non-surgical periodontal therapy, so I'm curious to see the
Ooh,
differences actually.
me too.
Yeah. Well, I one of the main things for me in mind, so I see most of now, I have a different patient base that comes in. Anyone who comes to me, I'm a fee for service. My doctor is extremely well known in the biological community, so people seek him out from all over. And the people who come to me already have a very high dental and health IQ.
Mhm.
I have conversations about supplements and fulvic acid and ozone and, bone regeneration. And I have these conversations that I would have never had if I was in a normal everyday practice or what I learned in school.
Mhm.
So I already feel really lucky. And I have so many people in my mind right now that would be all over what we're talking about. And I am rip roaring ready to go. So one of the main things when I do have, and we attack perio very early. I do not put up with a single 5 millimeter pocket. If you have one 5 millimeter pocket with bleeding, I'm going to do a site scale with your prophy. And so I do guided by, so on my, let's say full 4 quads, right? I actually get a 4 quad patient, which isn't very often. Um, if I see one 4 quad of non-surgical periodontal treatment a week, that's rare. Like I really don't have a lot of SRPs that come in because of my patient base. But all the new patients go through, sort of this very strict our initial new patient assessment with our doctor is 3 hours long. We have a CBCT, we do the full analysis, we look at airway, we had a spectra for a while. Now, we've just brought in Pearl and Overjet, and so we're bringing in a lot of this technology that really helps us assess and then reconfirm. And I feel
Mhm.
like this is an amazing tool that we can bring back in.
Mhm.
Anyway, so when I have somebody, I don't do anesthesia on most of my patients. I have a synapse. I have Orachix as needed. I do have anesthesia, but I don't use epinephrine because most of my patients are so crunchy that we don't want chemicals at all. And so I have 2 hours to do 4 quads for most people. I do a full mouth of, well, first I do the GBT to get rid of all the soft plaque. Then I do a round of laser. Then I do their scaling. I have a PAs on. I also have a Cavitron. Don't tell everyone. And so I will hand scale and I will use assisted mechanical scaling. And then at the end, I go back with the laser as well. My water is ozonated. So I do use ozonated water. So I feel like I see a lot of really good results. I feel like my patients really listen. I do give people toothbrushes. I do have their x-rays up. I am crazy. I am a fire hoser. I am guilty of that. I'm going to be like, listen, I've got you for 2 hours. You take those headphones out and listen to me because I don't want you to ever come back. My goal is to never make you do this again. And so I really
She can
genuinely
be
see
aggressive.
Slightly. Oh, I'm a tough lover. I'm not the nice hygienist. I'm gonna be like, "You did this to you. I didn't do this to you, and I'm here to help you. Like, you came to me." So,
Your
and
lion
it's
personality.
I I'm here. You're
He's
gonna know when I'm in the room. So, and you're gonna know that I'm your hygienist, and you're gonna be like, "Gosh darn right now, I know everything." But I think that there's a place for me to be able to say, "This is what you brought me, and let's retest," because I do have a 6-month, I'm sorry, a 6-week reeval, and I
okay.
do have patients on literally 1, 2, and 3-month recalls. I am not messing around because it is my job to make your mouth not bleed. And
Yep.
so if I don't have all the information, this person who's in my head right now, I see him every 8 weeks. He brushes, he water picks, he tongue scrapes, he electric toothbrush, he uses a really high quality toothpaste, and this kid comes from a healthy, crunchy family. He's in his late 20s, has fantastic everything, and every time it looks like I punch him in the face.
Are
Every
you
time.
sure
Mhm.
has he been to a functional medicine doctor, had blood testing, been checked for diabetes, autoimmune, all different things?
So he says not recently. And so this is where I'm also curious,
Mhm.
could these tests, I mean, what if all of a sudden you could see an A1C marker or
Yeah.
whatever? What else can we
You
see on
can do
these
a lot. You
slides?
can do
Like,
some of these things chairside. With that particular patient, if you so to me, like our job is, and I have like this amazing biological dentist that always says this, and I love it. She's like, stay in your lane. And she's,
Mhm.
I mean, she's like ultra, biological, but she's also still like, stay in your lane. And she's taking the first functional dentistry class. And then I'm starting the functional dental hygiene class in the fall, and I'm so excited. But she's been sharing with
Mhm.
me tidbits of what she's been learning so we can nerd out. But
Mhm.
she's also like talked about patients that she's had that she's done they've done everything right, and they're still
mm-hmm,
not seeing resolve. And that means there is
mm-hmm,
something going on. She actually had a patient, such a similar story of what you guys were doing, and
Mhm.
this young boy was actually diabetic. He was type 1 diabetic.
mm-hmm,
And it was like
mm-hmm.
there was so few other signs, and they caught it way late. And the parents are very well educated parents, I mean, very, very,
Yeah.
very knowledgeable family. And so I think it's it's such there's things that can be happening in our immune system
Mhm.
that are just blind spots
Mm-hmm.
because the
Yeah.
person doesn't
Yeah.
match the profile. And so we think
Yeah.
like, what else could it be in their mouth? So to me, it doesn't
Exactly.
sound like he has gum disease. It sounds like he has an immune
Yeah.
deficiency. Something's going on there. But I would also want a lab test. I would also like wonder what's on the microscope slide to
Mhm.
really be sure, because there's specific pathogens that you can't get rid of them with mechanical removal. Um, some of my well, I shouldn't say some. All of my biological practices do systemic antibiotics sometimes for periodontal disease,
Mm.
depending on the severity of with the lab test. I mean, I have multiple practices that like they'll do a lot of other modalities that a GP practice typically wouldn't do to help the immune system to be able to rid some of these pathogens.
Mhm.
They can avoid systemic antibiotics, but some of our very sick patients will do short durations. And so I wouldn't say that systemic antibiotics are really commonplace in perio in general across the United States, even in GP practices. Very common for
Mhm.
endo, very common for all this other stuff. But
Mhm.
for perio, we tend to think like, oh, well, bleeding gums, it doesn't look that
Yeah.
bad. But some of these infections are quite gnarly. So
Yeah.
to me, I'm like, don't guess, always test, don't guess.
Yeah. Yeah.
Yes. And I like a lab test before and at the 3-month mark ish,
Mhm.
2 to 3 month mark, because
Mhm.
it's kind of like if you're going to get somebody into an airway appliance, if you're going to get them on a CPAP, if you're going to do laser Fotona in their throat to like open up their whatever you're gonna do, like test
Mhm.
before, like, where are you?
Mhm.
Let's do the
Yeah. Mhm.
treatment. And now
Yeah.
Mhm.
let's do another sleep
Yeah.
test afterwards. How do you know it
Yeah.
was successful?
Yeah.
Because
You need a
sometimes,
Exactly.
baseline. Yeah.
yeah,
Exactly.
we're chasing
That's
Well,
big
and
I
I
wish
always tell my patients when
gosh.
they're I always ask because I go through like thorough medical history, and I tell them like, I mean, a lot of men have never seen their primary care, or it's been 5 or more years, and I tell
Mhm.
them you need to go get your blood work. But honestly, I say think you should go see. I never recommend Western medicine because all our labs always look good. I tell them like you need to. I would go to functional medicine because they're going to read those
Mhm.
labs a little bit differently.
yeah, they
Yep.
are. And take a lot more.
But I
They
do
do.
similar to Lauren, like I go through the medical history, we do all the things. Like I use the lasers, we have the GBT. I love perio DT. I think it's wonderful. We just got that. I see really great results with that, and then I literally just go into home care.
Yep.
I recommend oral probiotics. really high quality toothpaste, tongue scraping, water picking, all the good
But
things. I
like
need
she
to be.
just said,
Yeah.
there's some of these that can't respond to mechanical disruption.
Mhm.
So, I mean, now I'm thinking a
Yes.
spirochete, right? Because
Yes.
now I know it's a corkscrew, it's down in the gums.
Mhm.
So now I think we have to hit this middle
Yeah.
80%, right? Like you have to address these things that can be addressed.
Yeah.
And then you retest and you say, okay, we've done all these things, right? And I'll ask patients to confirm. I'm like, please tell me, walk me through your home care routine.
Mhm.
Let's make sure there isn't something that we could
Yeah.
address right here
Right.
before escalating it
Mhm.
to the next need. So, okay, so now we've already assessed it's been 3 months. They're doing literally all the things we're asking them to do. They still have 6 millimeters of bleeding. What now?
So my first thing would be, did you do a lab test? So if you did a lab test and their first lab test came back insane, red complex, AA, FN, like
Mhm.
what do they have? What there and there's a lot more bugs out there than what these tests look for, but like we're
Yeah.
we're trying to catch the majority, right? And they live
Yeah.
together in groups. So depending on what that lab test looked like, a lot of my biological practices that have a microscope, they always also do saliva testing. So we're gonna take our saliva test to send to the lab to like confirm like what we see, and they're gonna take that to diagnosis. They're gonna go through their periodontal treatment visits, whether that be 2 or 3, however that is. And then depending on what that lab test looks like, they're gonna review it with the patient. And many of them will wait to do a systemic antibiotic if at all. They'll say like, let's just see how your immune system,
Mhm.
treats
Mhm.
this. At 6 weeks, we're gonna reevaluate. First thing we're gonna do at that appointment, we're gonna look around. I'm a huge fan of photography, so I'm gonna definitely take some pictures, some retracted photos,
Yeah.
because I'm obsessed with that. And then I'm gonna take a
Mhm.
microscope slide and I'm gonna see, did we decrease volume and decrease motility and how much? Because if a patient's not responding, it's very obvious. Like they still have a gazillion spirochetes, motile rods, parasites, white blood cells all
Mhm.
over the place. There's creepy crawlies all over. If by 6 weeks you're not, because it's 6 weeks, like I do my 6 week after the last time I hit their mouth. So I'm giving them a
Mhm.
full 6 weeks. They know the protocol. They've come in for periodontal treatment 1, periodontal treatment 2, always full mouth every time. So if at 6 weeks they're not better, then a lot of the teams are considering a systemic antibiotic. And then they're going to get the patient back in another 6 weeks
Mm.
to see, like, now was
Yeah.
it successful? However, if they look great at 6 weeks, regardless of what they had on their lab test, if they look awesome, their immune system's fighting it off. Like they're good.
Mhm.
Good. Don't do a systemic antibiotic if you don't need to. Like, let's not
Yeah.
nuke everything. Systemic
Mm.
antibiotics, I think, are important to treat respectfully and be smart about it, because they're going to kill your good bacteria. So
Yeah.
you must have a protocol to replenish. So functional medicine teaches weed, seed, feed. So functional medicine does still do some systemic antibiotics, but not just, oh, just throw it at them, kill it all, and
Mhm.
let's move
Yeah.
on. Absolutely not. We're
Mhm.
talking about diet. We're talking about probiotics and prebiotics. We're talking about eating fermented food and
Mhm.
getting rid of some of these carbohydrate, things that are feeding all the bad bugs. And so there's a whole process. If you're going to go down the systemic antibiotic route, we need a long maintenance phase to build back up that immune system. And that part is so rarely done in modern medicine. Now, in functional
Mhm.
medicine, in biological dentistry, it's more commonplace because these practices have taken the additional continuing education, tons of classes on
Yeah.
what are the best practices there. And if the patient doesn't want to do an antibiotic, then don't make them.
Yeah.
But
Mhm.
if they don't get better and you do another lab test at 3 months and they're still really high in the pathogen load, well, now you need to have another plan B. And there's
Yeah.
there's there's
Mhm.
there's other options that we have there, but it's gonna be individual to the practice, because I've worked with so many practices that have just very different philosophies on the way that they practice, their practice mission, their vision, the way that they care for their patients are different. And that's
Mhm.
great
Mhm.
because all of us
Yeah.
humans are different too. So we want to find somebody that's a
Yep.
good match. So for me,
Yeah.
it's like, okay, what is your plan when this happens though? Like for that particular practice. And the biological practices tend to have more more tools in their toolbox,
Yeah.
Mhm.
which is helpful.
Mhm.
That was a long rant. Sorry.
No, 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 it's good
No,
because I
no,
feel like a
that
lot
was
of
a good
us who
rant.
do any of this stuff, it's like we do it and then you get the results and then you're like, okay, you do the things, because I've worked with HR5 and Laura Hooper. So I know a little bit, but then it's like when you're not seeing those results, then you kind of get stuck because you're like, where do I go from here?
Yep.
Mhm.
Yep. And
And I
the
think that's where
systemic
a lot of the
antibiotics are not
defeat
always the answer.
happens.
Yeah, I mean, so many of our I have had multiple patients that have had gums that don't look good, great home care, bleeding, and I've done a lab test and they've had nothing.
Yeah.
Zilch. And so in the early days, I had no idea. I didn't even ask the right questions. Later on in
Mhm.
my life, I r it's like you look at that patient, they had history of tons of root canals, history of lots of antibiotics as a child, history of just pretty much
Mm.
their immune system and their microbiome in their gut was nuked. They don't have a
Mm.
microbiome, like, their gums aren't healthy because they don't have good bugs, they don't have bad bugs, they're wiped out, and so, of course, he
Mm.
didn't see anything on the lab test, and so that
Interesting.
person, I would send to functional medicine to get their gut right again, because if your gut is not right, the rest of your body is not absorbing nutrients the
Mhm.
right way there. I mean, there's so much to it, and so,
Hmm.
the body we've so
That's
often well, every part of the body we compartmentalize in Western
yeah,
medicine.
yeah. Why is
Wow.
that, you know?
Oh, I'm so
No, this
excited
is
about this.
because I just moved here like a year ago for right? So I'm trying to find like found ENTs, I'm trying to find like functional medicine, I'm trying to find like rheumatologists because I want to be able to collaborate and like have
Yep.
somewhere to send these patients. So remember, Lauren, I was talking to you, I had a patient last week whose blood pressure was 246 over 150.
Whoa.
And I was
Whoa.
like, oh, so I was working at our other office yesterday and the girl was like, "Oh, she's like, so and so just called and scheduled an appointment because they do airway there." And I was like, "Oh, thank God," because I was worried. I'd called him to follow up and see how he was doing and he never picked up, so I was worried. But at least
Mm.
he listened to me because there is a sleep apnea situation there. He was diagnosed with high blood pressure. He's not on his meds. So
Mm.
it's a little, slow progress is better than no progress. It's
Yeah.
like that drip system, it's like they might not listen right away, they might not get it right away, but the more we talk about it,
Yeah.
the more,
Yep.
hopefully it'll get through. So I think a lot of good information today. You've invigorated Lauren over here, who's going to go start saliva testing, I think, Monday.
Right? Oh, yes, we're gonna talk afterwards because, I mean, we're already at 56 minutes. I think
Uh,
we could talk for 7 hours
uh,
with you. It's amazing.
I
Golly.
I love these topics. I could talk about it for days.
It's
uh,
awesome. Well, I think there needs to be a part 1 and a part 2.
yes,
Gosh, I
let's
feel
do
like
that.
we just
I'm like, I feel
scratched
like
it.
I didn't even talk a lot, but Lauren has great questions because she generally, is interested and has never done it. So I feel like,
Right? I remember it was a few years ago at RDH Under One Roof. So I think it was 2022 or 23 was the first time I ever saw Laura Hooper talk about salivary diagnostics and testing. And the thing that stands out to me is that was a 2-hour session and I walked into that room a little bit late and I needed to pee already. But I was so interested in what she said that I didn't move for 2 hours. And I was fascinated by what she was talking about. And it was like the early days of trying to get a protocol. And she was talking about this bacteria needed this antibiotic, this bacteria needed this laser, this bacteria
mhm,
does not respond to SRP.
yeah,
And I was just like, I had no
yeah,
idea that this was something that could be
mhm,
available. And I'm in love with how this is progressing. And I
yeah,
care so much about these different biomes. And now
mhm,
I'm like, what can I do with the gut microbiome? And we have a couple of really good functional dentists that are practitioners and healthcare doctors that we send people to, and I'm just like, the collaborative, like, function that can happen right now is really exciting. And that's my, like, love is collaboration in general.
yes,
Um, even it's just amazing. So, I mean, I believe in collaboration all the way across. Everyone needs a team,
mhm,
and I think that what we've touched on is how we have taken such responsibility for these patients that we have taken them so far. I need a team. I need other tools.
yes,
And we've done everything that I know how to do. This is
mhm,
my scope of practice. I can get you here. Let me pass the baton on to functional, onto ENTs, onto the gut micro. Let's do that. And this is really a really cool fire.
mhm.
Um, and I mean, I'm kind of sad about my microscope that's been staring at me.
So you have
So
one.
we
We'll
have
we'll
one.
we'll
I
I
talk
have
have one
one.
too,
afterwards about your next
and
steps.
it's been staring at
Yes.
me too, but for the
Yeah.
hygienists out there that are doing this on their own, I see you, I hear you, I am
Yeah.
you.
Yeah. You are you.
If you
Well,
don't
and
have the
that
support, it does not matter. You keep fighting the good fight. and it can be exhausting, but it is 100% worth it.
Yeah. Tasha, do
So,
you have for those of us that can't do everything that you're doing, I know there are so many at-home things people do now. I mean,
mhm,
if it's Viome or it's something like that, are you allowed to? Do you ever? Where is your comfort zone with talking about these adjunctive things that patients could potentially like? I consider it like an aura ring. An
yeah,
aura ring is the first step to get
Yeah.
my patients to understand there is a desaturation, there is something happening. You can begin to just gather the information. So, what if you wanted to know more by one of these at-home tests? Um,
Yeah.
is
So
that something?
Yeah, so I mean, there's so much that people can do truly to improve their oral health, even if they have periodontal disease and they don't have a dental practice that they're seeing. I mean, this podcast, for one, gives a ton of information to people, and I
mhm,
think that's amazing. And that's the reason that I
Our
also
goal.
started my podcast because I wanted to educate the public on
yes,
what's available. Because the the thing right now, because there's so much technology, so much information out there, is that our
Hmm.
patients are actually getting ahead of us as dental
mhm,
professionals in the mouth body connection and how these things are related. And when you're in the trenches, so to speak, it's like 10 to 17 years are what the studies are showing is that when new science and new studies come out, it takes that long to get into private practice,
Mhm.
even longer
interesting.
to get into school. And this is for physicians,
Mhm.
this is for dental
Mhm,
hygiene. So there's
Mhm.
this huge
mhm,
lag. And so I think there has to be a
yeah,
place for patients to get that. And so I'm creating like a catalog, if you will, like on my mouthymatters.com website. Right now, I just have like a 6-minute guide to getting to having better oral health. But I think the foundational pieces are really ridiculous, which is going to sound silly, but it's so important. Is how do you truly brush your teeth?
yeah,
So
mhm,
like brushing your entire mouth, like the entire vestibule, your palate, your cheeks, scraping your tongue. I love a copper tongue scraper because it's antimicrobial. Spending
yeah,
2 minutes at least, not because you have 2 minutes of garbage on your teeth, but because you need to disrupt and disorganize the biofilm.
yeah,
Using a water pick, I mean, like I should invest in water pick or something. I truly love water pick, the
mhm,
brand with the pocket tip,
Agreed.
making sure that you're using the right technique all around your mouth.
yeah, mhm,
I really love IO rinse, like molecular iodine. You can even get the concentrate on Amazon now. That's a really great one, super safe on
mhm,
implants. Um, Using a water pick every day, whether you think you need it or not, don't use it like floss.
yeah,
Again, using the right technique. You mentioned
mhm,
probiotics earlier. One of my favorite probiotics now is Daily Dental Cares. Emily Stein is the maker of that, and it works different than other probiotics. And that's why I really love it for a hostile environment. So, meaning the patient has bleeding, there's inflammation, or there's a lot of dental decay. So, with
mhm,
probiotics in general, we're adding a lot of good bugs to the mouth, but unfortunately most of them will pass through because they don't want to live in a nasty neighborhood. So like the person like sucks on
Mhm.
great lozenges and those probiotics are these beautiful good bugs and they're like, "Oh my gosh, I'm in the ghetto." Pass on through.
Yeah.
So
They
what
don't want to
okay,
stay.
yeah,
product does, and it's called Protectin, PRO, capital PRO, and then it's with a K, Protectin. She uses
okay,
a decoy sugar molecule and probiotics. So essentially, the unhealthy bacteria see the decoy sugar molecule. It's actually fiber
Mm.
and it starves them. And so you
Mm.
suck on like
oh,
a so if you have a hostile environment, bleeding gums,
mhm,
inflammation, any of that, you would suck on like 4 lozenges a day because most of the time we're eating and snacking and things like that
yeah,
multiple times
Mhm.
throughout the day. They also have a water, like you just add a powder to your water. And the mints taste delicious and you just suck on them 4 times a day and that helps to starve the bad bacteria while
Mhm.
feeding the good bacteria. She created this
Mhm.
product. She like was looking at a microscope since she was 20. Her grandmother, who was her primary caregiver, unfortunately passed away with a stroke and some complications. And she really felt like it all happened from her mouth. Started with a root
mhm,
canal that went bad with an extraction, all this kind of thing. And so that's really what set her off on this path. And it's just it's I love that the mechanism of action is a little bit different. So then from there, after you've gotten to a better environment, then add some of these other really great oral probiotics because
mhm,
our food, our nutrients, our soil is not what it was 50 years
mhm,
ago. I mean, what did
Mhm.
Dr. Carver told me the other day? She said that you need to eat 8 oranges in order to equal the vitamin C that you need in a day now.
wow,
Wow.
So even if you're doing the right things, it's just nice to supplement to just give our body a little bump.
Yep.
So which is
does
Yep.
healthy.
blood
We need
orange San Pellegrino count? No? Okay.
No. No, it does
But it is
not.
delicious. Makes you happy.
No.
So those are
Does
some
it have a BPA lining?
So
See?
that would be like
Oh,
my first 3 is like knowing how
Oh,
to brush
man.
properly, using the water flosser
Yeah.
properly, doing some protectant. Those things, absolutely incredible. With Viome, there's 2 different Viome tests, like direct to consumer. They have some customized probiotics that they can make for you. You just send in your saliva. So if you
I
go to
did that.
and so that's helpful, but in the United States, the regulations do not allow lab testing companies to send all of the science and what their findings are to the patient. You have to use a
Oh.
professional, you have to use a doctor. So that's why Viome also has Viome Pro, and that's where it's like your other, saliva testing that dental practices do. So with that test is crazy. It's really, really cool. They use mRNA. We could
Ooh.
rabbit hole on this. I won't go
So,
down the
yeah,
rabbit
I didn't
hole, but it's
that's
a
some good information. Yeah, because I did the regular Viome, and it was a hot mess, so God knows what the
It
Viome
you
Pro
you
would
just
show. But,
don't get you're not allowed to get, like, some really nitty-gritty details. Bristle also
That makes
has,
sense.
direct to
Yeah.
consumer, and then you can have a
mhm,
phone call with a trained dental
okay,
hygienist to read your results, and so that's kinda how they get around that piece of it as well.
okay.
So some of the lab testing, is really tricky direct to consumer due to regulations in the
Mhm.
United States.
No,
Okay.
very
That's
cool.
which I think
Yes.
is appropriate because all of us want to treat ourselves with Dr. Google.
Yep.
Yeah.
And,
Well,
then
yeah.
we're going to go buy whatever TikTok
Yeah.
shop is going
Yeah.
to tell us is going to fix it. So, okay.
They gave me all these
Wow.
promises.
Yeah.
Yeah,
False
exactly. Oh, I
promises.
can't believe it. I bought it
There's
on sale.
I tell you, there's pros and cons to the whole TikTok, because then you still have people coming in and they're like, "I watched on TikTok.
Yep.
I think I have airway
Yep.
issues." So it's like, great. Like,
Yep.
there's
Yes.
a lot of misinformation, but there's some at least good information out there that is getting them to ask the right questions
Exactly.
when they come in.
That's
So,
That is 100%. I get all these
yeah,
looks maxing, jaws maxing people who then start doing whatever
yeah,
Oscar Patel is telling
yeah,
them. And then I'm just like, I'm thankful that it made you curious. Let
Yes.
me tell you the right way to do
yeah.
this now.
Yep.
So, I mean, I think that it's an opportunity to teach people, but
Yes.
um I'm super sad because my phone's at 5%.
Of course it is.
And so
Lauren's phone is at 5% at the end of every episode.
it's because we filmed 2 today.
Do you not
Ah.
have a charger, Lauren?
I my phone is I'm not on my computer, I'm on my
Okay.
phone. So
All right. Well, we're going to have to do this again, Tasha,
yeah,
because there's a lot of good
absolutely.
information. I'm
This
saying
is
if
so
you
good.
have time after in like 10 minutes, if you want to hop on and get in, we can have a
Yeah, because
conversation.
then I can plug my phone in and I can
Yeah,
stay
yeah,
on
let's
I will
not
because I
edit.
don't
distract
need
I
my
will edit all
microphone then.
this off. Don't worry.
This is why.
Yeah. But
That's funny.
I'm going to edit that out. Lauren's making me
Oh,
edit stuff. So
I
anyhow,
also hit mute when I did that because I hit mute.
all I see is edit, edit, edit.
I love you. Extra work. All right, Tasha, for
Wait,
the end of this
yes.
episode.
I wasn't going to let just her go without give us all your information. Where
Yes.
can the
How do
people
people
find
find you?
you? Yes.
Okay, so you can go to mouthymatters.com. And if you're a dental professional listening, there is the little button that you click that says I'm a dental professional, and you can get my verbal scripts to helping patients understand their gum infection. You don't have to have a microscope for that. Sheet is a non-microscope friendly. If you
Good.
are a regular human that's here for your health, on mouthymatters.com, you can say that I'm here for my own health, and you can get my quick guide to 6 minutes to a healthier mouth. Otherwise, my Instagram is Tosha RDH, and my website is TOSH, TOSH, period, CARE. Tosh.care is my company.
Please look
Yay.
for her. Some great
Please.
information. I
Yeah.
listen to your podcast on my way to work. It is
Oh, do you?
fantastic.
Oh, thank you.
I have learned some great information
I
or
have learned so
things
much.
I didn't know that I've learned or things that I knew but forgot. So thank you
Mhm.
so much. So
My
please
pleasure.
go listen to Mouthy Matters.
Yes.
And we
Be
will
inspired.
have Tosh again here soon
Mhm.
because we have a lot more questions.
Part 2. We're going to have to
Yes.
film part 2.
But thank you for joining us. Please go to
Thank you.
the unhingedhygienist.com too and subscribe, like, share. But we will see you all back here again next Wednesday. Thank you so much.